it's going to be a long session. So, cranial nerve examination is a very important assessment that you need to learn to do rapidly. But in order to be able to do it rapidly, guys, too much ambient sound. Things in order that need to be done properly to get the clinical sign, right? Just to recap, do you all remember the 12 cranial nerves? Okay, olfactory nerve. First cranial nerve provides the sensation of smell, olfaction. Where is the olfactory mucosa located? In the roof of the nasal cavity, right or not? Okay. Second cranial nerve is your optic nerve. It provides you with a vision. Now, a problem in vision, how will a patient complain to you? I'm deviating out a little bit since the last clinical session. How would a patient complain of visual symptoms? That can be double vision, yes? Some? Is the only way that somebody would complain to you? Blurring of vision. What do you mean by blurring of vision? So is double vision and blurring vision the same thing? No. Okay. A breakthrough. So what is blurring of vision? Huh? Okay. Inability to focus. Okay. Some more? Anybody else? A drop in visual acuity. So you notice in this small group of people, we have so many opinions. So imagine patients at large will have even more opinions, right or not? So when somebody comes to you and says they got blurring of vision, it is our responsibility to find out what is intended or explained by the patient. So you ask them, it can either be a reduction in visual acuity, where they are trying to look at a particular object, but they are not able to see it. Right or not? It's blurred, the margins are not clear. Second, it can be diplopia or double vision. When you are looking straight, you see two images, not one. Right? And diplopia usually occurs due to an asymmetrical function of the muscles of extra. Guys, can somebody step out and ask your friends to have this discussion somewhere else? Please, if you don't mind, on behalf of the group. So if there's an asymmetry in the muscles of extraocular movement, what happens is there's two images hitting your retina. So you perceive it as two images. And these images become most prominent when on attempt at or looking in the direction in which the extraocular muscle is deficient. Alright? So this is diplopia. And the third kind of abnormality in vision is what? A visual field deficit. Meaning to say, when they look straight, they can see. But they are part of their visual field is like somebody is hanging a black cloth and blocking their vision. Always complain because they look straight, they can see. But some of the things that can commonly happen is they tend to walk into things, or they can have accidents and not realize it. They're driving and suddenly say, oh, I turned and out of nowhere this motorcycle was there. So basically because they have lost their vision. I had a patient who always kept missing the bus to the hospital because she had a superior temporal deficit due to a pituitary tumor, and she could never see the bus number. So by the time the bus came and she can actually see, it's too late already. So this is real life problems that people have, So we have to ask. Okay. So 1 and 2. 3, 4, 6 is your 3, 4, 6. You will have diplopia because the extraocular muscles. Cranial nerve 5, the trigeminal nerve provides innervation to the sensory faction of the face. Right or not? Pain, temperature, touch. It also supplies the muscles of mastication, which are the temporalis, the masseter, and the medial and lateral pterygoid muscles. Besides that, you go on to your 7th cranial nerve. Your 7th cranial nerve innervates the muscles of facial expression. So it provides, allows you to smile, to purse your lips, to raise your eyebrows. So these are the things that we look at when we're evaluating a patient. 8 is the vestibulocochlear nerve, and we test it usually using the whispering test or the Rini and Weber's test. Usually vestibular function is only done in detail if there is a vestibular dysfunction. Something we can do something called a Hall-Pike maneuver, but all that is definitely not related or required in a basic cranial nerve neurological examination. Okay, so from 8 we head on to 9, 10, 11. We are looking for You're looking at the palate, you're listening to the sound of the voice for dysphonia. You are assessing the palatal movement, uvula position, and the ability to or the presence of a gag reflex. And lastly, of course, or 11th cranial nerve, you assess for shoulder shrugging and the sternocleidomastoid function, ability to resist movement. And last, of course, is the hypoglossal nerve. You look for tongue deviation or impaired movement of the tongue, right and left rapid movement of the tongue. Alright? Okay. Shall we start? Okay. So before any examination of any sort, always boleh. So I like a patient to be seated either on a chair at the side of the bed or on the side of the bed, whichever one lah. I think since the group is big, and at least people can see. Can I have another chair? Thank you. The first bed, through the door. Cuba tutup mata. Jangan takut. Boleh. Okay. Ask him to occlude one of his nostrils. Boleh bawa atau tidak? Bawa apa? Mau yang baik atau tak baik? Wangi ke busuk? Wangi. Tutup. Tukang belah sana pula. Yang ini? Boleh bau. Apa ni? Wangi juga. Okay, bagus. So basically you just need to know whether he can smell or not. Differentiating the cause or the source of the smell sometimes is more of a higher mental function. As long as they can perceive the odoral stimulus is adequate. Right? So olfactory nerve. What's next? So before you that, ada pakai spek ke tidak? Tak. Okay, very good. You should ask this. Right? Cuba. Boleh membaca. Cuba tutup mata dengan. So most of this is known as a pocket Snellen chart. Is used to test visual acuity at the bedside. Most of them have a predefined distance that you are supposed to use. Right? So you should know what is indicated for yours and measure on your body roughly what it corresponds to. So next time, every time you measure, you just have to put your hand. Okay, you know this is the point. Okay, and you hold the thing here. Don't assume my arm's length and his arm's length is the same. No. Okay. So once you've done that, so betul-betul lah. Hold it forward. Tolong baca. Tukar mata. So you see, his visual acuity, you read according to the what is written here lah. So here it's given in 20 inches and feet, compared to in your some other charts it's given over 60. That is typically a Snellen. This is a Rosenbaum. You should know what is written on your chart. Don't have a chart which is written 20 over 40 and then you say 6 over 60. These are things which how you get into trouble in exams. Okay. Now, in order to do this more eloquently, my own examination card, what I've done is I've stuck a tongue depressor at the back here, so I can hold it up like this rather than have to hold it like this. You know, it's something you tend to fumble with your hands. So you're showing the card. You use the pointer and you can point. Looks nicer. Showmanship. All right. So visual acuity done. Now we go for visual fields. Testing of visual fields is you usually use a pin head. Why? What color pin do we use normally? Red or white? How many people say red? How many people say white? Raise your hand, don't worry. So democracy here at least. How many red? This is red. All red. Okay. We are testing the peripheral visual field. Right or not? The peripheral visual field is basically the peripheral retina. What type of photoreceptors are located in the peripheral retina? Cones or rods? Rods. Rods are color or black and white receptors? Black and white. So which pin do you think will suit this job better? White. Red or white? White. So when you are doing visual fields, peripheral visual fields, you use a white pin. Okay? Now when you are doing this test, it is known as the confrontational test. You must make sure you are distance a good 1 arm's length distance of the patient. His eye and your eye must be at the same level. Okay, cik? Nampak saya? Tutup mata sebelah, gunakan kaos saya. Okay. Tengok hidung saya, perhatikan hidung saya, jangan gerak mata. Okay. Nampak atau tidak? Nampak yang putih ni? Okay, before that, okay. Nampak ni? Test the central field first. Warna apa ni? Okay. Nampak ke tidak? Nampak ke tidak? Nampak ke tidak? Okay. Terus macam tu. Nampak ke tidak? Kalau tak nampak, cakap tak nampak. Okey. Nampak ke tidak? Nampak ke tidak? Nampak ke tidak? Okey. Kekal macam tu. Nampak ke tidak? 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 Bagus. Okey. Tukar mata pula. So you come test all 4 quadrants. Nampak? Nampak ke tidak? Nampak? Nampak? Nampak ke tidak? 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 Nampak? Okay, so you see a tested all 4 quadrants. Simpler way to do this is kekalkan tersebut. Okay. Jari mana yang bergerak? Sekarang? Sekarang jari mana bergerak? Okay. Sekarang? Okay. Tukar mata. So this way you rapidly test the 4 quadrants. You can do this. But I find that if you do it correctly, very fast you can do the visual field. But granted, you give the correct instruction, you make sure you are at the same eye level of the patient, because it's known as a confrontational test. That means you must be confronting the patient accurately. You must give the right instruction, test the central field first, and move in on each quadrant. Okay? So visual field done. Now we go for pupillary light reflex. Who has a energizer torch? The black torch with the black top. Yes, I am brand ambassador for Energizer. Come. I don't like the white torch because it's too bright. So what is the first principle of medicine? Huh?
Do not harm.
Do no harm. So don't cause pain to the patient. Okay. So pupillary light reflex. I think some groups I might have taken. The last week I was just demonstrating how you do this. So you can shine it like this, of course. But in order to be able to see it very clearly, the eyebrow a little bit, not the eye, the eyebrow. Come from the side, press, and let go. Can you see? Boleh je. Tengok depan. Can you see? Can you see the eye? Come nearer. Come nearer, come nearer. See, notice this patient is very sensitive. The previous group one has noticed that the other patients are very, but see in practice there will be varying type of patients. We have to adjust our technique to elicit the sign in everybody. Can you see?
Yes.
Okay. Those who can see, move backwards, let somebody else come forward. One provides you the ambient light to just see what you're doing without stimulating the eye, alright? Well, this side shine. Can you see?
No.
Can you see?
Yeah.
Yeah, nah? See or not? Now, sometimes you can ask them to do this.
Thank you.
Okay, boleh lah. So, to reduce, to prevent the chance that the ambient light from that side hits on this eye. But if you ask me, it's a matter of refinement of technique lah. If your technique is unrefined, then you have to do all this. But if you do the technique correctly, you can easily elicit this sign. Okay. Now we progress to something known as the afferent pupillary defect assessment, known as the Marcus Gunn phenomenon. If you keep for that, right? How you do that? Okay, you go ahead. Something known as screen cross test. One, two. So when you shine on a side that has an afferent pupillary deficit, the pupil will dilate because the afferent part of the reflex is not picked up, known as RAPD positive. Okay, so once you have done this, now what we can do? We can do your extraocular movement. Okay. For this, do we use white or red? White. Good luck. It is good luck, but that's not the reason. Alright? We are testing, see, when you are looking for extraocular movement, the ability for the macula fovea to focus on one particular object. So we are testing the central focus of vision. In the central part of the macula, which photoreceptors predominate? Cones. Color receptor, right? No? So red is quite easy to see, you know. Nampak berapa? Jangan gerak kepala, ikut dengan mata. Boleh. Okay. So if you're very cooperative patient, you can just do it like that. Okay. Ikut dengan mata, jangan gerak kepala. Nampak berapa? Nampak berapa? Nampak berapa? Okay. Ikut dengan mata, jangan gerak kepala. Nampak berapa? Nampak berapa? Nampak berapa? Okay, this is one way. Alternatively, sometimes some patients are not very cooperative. Hold the eyes up and hold the head so the head won't move. Nampak berapa ni? Ikut dengan mata. Ikut. Nampak berapa? Nampak berapa? Nampak berapa? Sebelah sini. Nampak berapa? Nampak berapa? Nampak berapa? Okay. So you see, you take him through the whole H movement. So if there's any asymmetrical movement, immediately they will complain of diplopia. Once that happens, you test each eye separately, all directions of primary gaze, right? H is all that is necessary. You don't have to do like some one this way, that way, everywhere, you know. H is already sort of separates out all the primary direction movement. Oh, by the way, before you do the extraocular muscles, have a quick look at the eye. Look for any obvious ptosis or squint. Squint or strabismus is a loss of alignment of the eye. It's either convergent, where it looks inwards, or divergent, depending on what cranial nerve is affected. So the extraocular muscle function is predominantly 3, 4 and 6. 3 controls most of the muscles except LR6 and SO4, right? No, lateral rectus is cranial 6, superior oblique is 4. So lateral rectus is lateral movement. Superior oblique, what does it do? Down and inwards. Alright? Okay. So once you have an abnormality, you test each eye and you can separate out which direction is impaired. Then you can determine what nerve. Ptosis is typically associated with the third nerve. A divergent squint, eye which is down and out with ptosis, is a hallmark of third nerve or oculomotor palsy. Lateral rectus palsy causes convergent squint. Okay, so that's extraocular movement. Then what we can do is we can do something known as a accommodation reflex. Okay. Can I make a pathway between you all? Boleh nampak dinding belakang tu? Nampak? Tak? Okey, tak apa. Buka dinding ke, nampak cermin atas tu. Okay. Tengok sana dulu. Okay, buat jari macam ni. Tengok sana dulu. Okay. Sekarang tengok jari. Okay, tengok luar dulu. Tengok cermin tu. Okay, sekarang tengok jari. Okay. So what happens in a convergence reflex? The eyes converge and then the pupils will constrict. So there are a few ways you can do it. Someone say, okay, tengok luar, ikut tangan saya. Some patient won't follow. If you do this, sometimes it is quite ganas. So see, notice immediately he drew back. So use the patient's own hand to do this. It's nicer. Tengok luar. His hand is, but see, my point of this, patients are heterogeneous. They are not all the same. So, but we need to see the results. And okay, another reason why I like to hold the eye is sometimes you can see, but eyes are a bit small, you will not be able to see clearly, and you must demonstrate the sign with certainty to yourself and the person you are demonstrating it to with confidence. I don't know. It should not be, is it there, I think. Neurology is actually very straightforward. Ada, tada. Right or not? Okay, so accommodation reflex done. So 3, 4, 6 predominantly already sorted out. We keep the fundoscopy for the end of the examination. Right? Now we go on to the trigeminal nerve. Can I have a new cotton ball? One is recycled. Don't recycle. So trigeminal, as I spoke to you all, it provides sensation of pain, touch and all to the face. So what you can first do is first have a quick look. Okay, ask him to buka mulut. Okay, lawan tangan saya, buka mulut. Buka mulut. While he's doing that, you can also look for any obvious wasting of the temporalis. You can palpate for the temporalis. Feel the masseter, digit, motor. And then you can progress. You can do the Georgic now or at the end, up to you. Sensation. Sensation, you can do touch and pain. Boleh rasa ni? Rasa apa? Lembut. Tutup mata. Ini dengan ini sama. Ini dengan ini sama. Ini dengan ini sama ke tidak? Sama dua-dua belah. Okay, bagus. So make sure you test and you compare. Sometimes you can even ask me, ini dengan ini sama. Because you may have a facial problem. I don't know. Sama. Ini. This is the thing about sensory. It's very subjective. I prefer this to that. Sharp. Okay. Boleh rasa? Rasa apa? Sakit. Okay. Dua-dua belah sama. Ini dengan ini sama. Ini dengan ini sama. Ini dengan ini sama. Ini dengan ini sama. Okay. So pinprick and touch done. Okay. Another important reflex you must do when assessing trigeminal function is the corneal reflex. Corneal reflex is an important reflex. Don't forget to do, because sometimes that can be the only thing that is deficient in an examination. Buka mata. Stand behind or the side of the patient, not from the front. Okay. Boleh tengok ke belah sana. Ask him to look at the opposite side. Jangan takut. Belah sana, on the side. So you see, where must you touch? White, black. Oh, ini previous group soalan bocor je. Okay, dah. The junction between the black and the white. Alright. So same thing. Don't put your hand on the eyebrow like that. Put it on. On the eyelid. Put it on the eyebrow. Because if not, you will not see the reflex. And just say there is no contraction. You should ask the patient whether he can feel or not. Because the efferent may be impaired while the afferent is still intact. Right? So corneal reflex is done. Proceed on to the cranial nerve. Okay, I'll show you Georgia first. Can I have some? Kabul. Paru. That's it. The Georgian is very non-specific reflex. That's why you can do it for completion's sake, but even an anxious patient it may be exaggerated. Alright? Okay. Facial palsy. How do you look for facial palsy? You inspect the face directly. I sit down there. Okay. You look at the face, you look for any obvious facial asymmetry. How do you see facial asymmetry? Sometimes you can see it in the resting state, or if not, the easiest way is asking to smile and show his teeth. Tunjuk-tunjuk gigi. Okay. When you do this, you can see the nasolabial folds. Right? So if there is lost on one side, that would suggest that there is a pathology in the facial muscles. Number one. Number two, you look at the angle of the mouth and asymmetry. One side droops down. That is a sign of facial palsy. Tutup mata. Paling kuat yang boleh. Look for incomplete eye closure or asymmetry in eye closure. So you see his is quite symmetrical. Cuba lawan saya, jangan bagi saya buka. Okay. Naikkan kening. Okay, so you look for symmetry in the furrowing of the eyebrow. Okay. How do you differentiate between an upper or a lower motor neuron facial palsy? Okay, so how is it different? Lower motor neuron, everything is
Upper part is okay.
in lower.
In low.
Sure.
Upper part is
Okay, imagine like this. In upper motor neuron, there is dual innervation, correct or not? But not to the whole face. So if you have upper motor neuron pathology, will there be sparing or no sparing?
No sparing. Upper motor neuron no sparing.
Upper motor neuron, there will be sparing because there is contralateral innervation there or not? Okay, see, the lower motor neuron are the lower motor effectors. Correct or not? If you lose that, no matter what dual, triple innervation, it's going to be completely gone. But in upper motor neuron, there is preservation, right? Or not? Because there is dual innervation. Understand? The preservation of forehead movement or not will differentiate upper and lower motor neuron facial palsy. Okay. Once you have done that, you can also assess for hyperacusis. You can just rub your fingers and see whether it sounds louder on one side. It will be louder on which side? The side of the lesion or away from the lesion? On the side of the lesion. Reason because one of the branches of the cranial 7 is the nerve to the stapedius. Stapedius' role is to pull back. When it contracts, it brings your auditory ossicles away from the eardrum to reduce the intensity of sound. So, however, if you have a pathology, it will seem louder because the nerve to stapedius is not functioning. Alright? A total assessment of 7 nerve will also include things like okay. Buat mulut begini. Ask him to purse the lips. Tiup pula macam tiup balloon tapi tahan. Boleh? Besar-besar. Alright? You can ask him to do that also. Now, anterior two-thirds, taste over the anterior two-thirds can be tested, but usually not routinely done in clinical practice at undergraduate level. Alright? Another thing you can do is you can assess for lacrimation. Right or not? Using something called a Schirmer's test. Also not routinely done at undergraduate level. Okay. So you're done with your 7. Now we go to your 8. Yes. Okay. Let me see. You ask them to close the eyes. At one side, you can still see the white of the eye. They cannot complete. The orbicularis oculi is dysfunctional. And when that happens, actually, there's another phenomenon that becomes prominent. Does anybody know the name of this phenomenon? What is Bell's phenomenon?
Yeah. Facial canal inflation.
Bell's phenomenon, not Bell's palsy. Bell's palsy is low motor neurofacial palsy. Can be due to multiple etiology, autoimmune, viral. Okay, coming back. What is Bell's phenomenon? Anybody? Nobody reads Kelly O'Connor. Oh, okay, fine. Bell's phenomenon is patients with facial palsy and incomplete eye closure. What happens is you will actually see the white of the eye on attempted eye closure or not, because it's not closing fully, and you will find that the eyeball deviates upwards. Actually, this is a normal phenomenon. When we close our eyes, our eyeballs will deviate upwards. But it only becomes prominent when you have incomplete eye closure. If not, you cannot see it, and this is known as Bell's phenomenon. It's a visible phenomenon seen when or in the presence of a facial palsy causing incomplete eye closure. It is not a pathological sign. Alright? Number 1. Number 2. It is not the same as Bell's palsy. Jangan mix up. Bell's palsy is an, I would say, not even hydrogenic, it's an unknown cause, postulated to be infective, inflammatory, low cranial palsy that involves. Okay. Come back to 8, 9, cranial nerve 8. Vestibulocochlear nerve. Predominantly, we are testing the hearing function, and you can test using the whispering test first. I'll go straight to the Rennie and Weber test. Alright? Rennie and Weber test we use ideally 512 better. Because by the time you're done, the 256 will finish vibrating and you have to keep hitting it again. Alright? 128 is too slow. What is the best way to get this to vibrate? You can hit it on here, but a nicer way is using the tendon hammer. Alright? Okay, hold the thing parallel to the ear. Okay. Ni lagi kuat atau ni lagi kuat? Depan lagi kuat atau belakang lagi kuat? Sekali lagi. Kuat depan atau belakang? Bunyi dia. Depan. Okay. So what does this mean? Air conduction is better than bone conduction. This is known as Rennie's positive. Okay, same thing on this side. Depan lagi kuat atau belakang lagi kuat? depan. So bilaterally, release is normal lah. Okay. Then you do a Weber's test. Paling kuat kat mana? Kanan, kiri atau tengah-tengah? Tengah-tengah. So this is normal, right? So there are two patterns of hearing loss that you will see in clinical practice. One is known as sensory neural hearing loss, the other one is known as conduction hearing loss. So in conduction hearing loss, what will the pathology be on the right side? Okay, or what will the Rinne's test be? Okay, I have right-sided conductive hearing loss. Rinne's test will be? Okay, so that is Rinne's what? Positive or negative? Rinne negative, okay, in conductive hearing loss. On the side of the lesion, Rinne negative. Okay, what about the Weber's test? Which side will it lateralize to? Ipsilateral or contralateral?
Ipsilateral.
Okay, ipsilateral, right? Okay. Why will it lateralize to the ipsilateral side?
Left to step yes.
Sorry?
It's blocked right.
That's right. It's not working right. So why? Understand the question or not? Okay. When you just say somebody has a right-sided conductive hearing loss, they will have a Rinne negative on the side of the lesion. And when you perform a Weber's test, the Weber's test will lateralize to the side of the lesion, not away from it. Reason is, Weber's test is assessing predominantly bone conduction. To the 9, 10, 11, 12. Right? So who has a beautiful uvula? The previous group, there are some gentlemen with the most interesting uvula I've ever seen. Bordering on abnormal, but it's normal. Right. So who wants to volunteer their uvula? Yes, sporting gentlemen, come here. Nothing will happen to your uvula. Oh, patient ada. Okay, mari. Save by the bell, we say. Okay. Look at the palate and what bunyi okay, so you see the soft palate moves upwards, right? You are looking for that symmetrical movement of the tongue. Okay, dongak kepala ke belakang sikit. Sekali lagi. Okay, can you see? Correct. Take turns. Tukar. This is something you can perform on each other. Huh? You can test each other. Sorry, Cik. Can you see the and you see that little red thing in the middle? That is known as the uvula. So you want to see whether it's in the mid position or is it deviated to one side. Okay, next group. But what I do in clinical practice, although you have to follow step by step, I usually do the tongue assessment one shot. Because after you have done the gag, sometimes the patient is uncomfortable, they may not want to cooperate with you further. Okay, come mulut sikit. First, inspect the tongue in its resting state. You're looking for any obvious vesiculation. Okay, jeling keluar lidah perlahan-lahan. Keluarkan lidah. You're looking for keluar, betul-betul keluar. Okay. Keluarkan lidah lagi. Okay, looking for any obvious tongue deviation. Okay, gerakan lidah dengan cepat ke kanan kiri. Cepat lagi. Okay. Rapid tongue movement. Okay. Sekarang tolak lidah pada bibir. Pada pipi. Okay, cuba tahan. Okay. Ulangi pula. Okay. So these are all the ways to test the power of the tongue. Right? So once you have done that, then you do a gag assessment. You need a tongue depressor. Can you open that? Just take out the tongue depressor and a swab. The throat. It is very rough, right? So use the tongue depressor as it should be used. Can somebody help hold the torch so that they all can see? Alright. Okay. Buka mulut besar-besar. Tongue depressor. Dongak ke belakang sikit. Okay. Tongue depressor depresses the tongue. Buat bunyi Okay, buat bunyi Okay. You touch the posterior pharynx. Okay, sorry. So you notice that? Okay, maaf. So you see, it's quite uncomfortable. If I had not done the tongue and he might be very angry with me if it's the wall. I say, okay, I don't want you to. So that's why I asked you to do the hypoglossal immediately. Yeah. Right? One shot. So you have to test both sides like this. I don't want to put him through that great discomfort, but see where you have to touch. Some people try the shortcut and touch nearer, or they shove this thing. It's quite uncomfortable. Huh? Okay, just if there is no reflex in your touch, you want to know whether that he can feel this or not. So these are two things you must check, right? Because afferent is glossopharyngeal, efferent is 10 cranial vagus nerve. Can somebody dispose of this? Any disposal boxes? Tolak muka, lawan tangan saya. Okay. Okay, belah ni pula, lawan tangan saya. Okay. Naikkan bahu, lawan tangan. Okay. and we are done. So you say, I like to end my examination by performing a fundoscopic examination as well as completing a motor and sensory examination of the lower and upper limbs as well as a assessment of cerebellum and kidney. Depending on the disease, you can even add in, I like to inspect the spine, but it really all depends. Why I tell you, they generally have a rule of saying this because in case you miss something, they say, oh, okay, you can proceed. It shows that you are at least thinking about these things.
Okay.
Alright? Any questions?
You mentioned the name of the test.
Which one? Test or phenomenon? Marcus
No,
Gunn.
no, no. Before that, earlier on, somebody's name is it the test? Couldn't get the name.
And bells.
No, before that, the I one.
What will be testing? The equity, feels,
Eye movement.
Maybe
or
eye
is it
movement.
lacrimation?
Before that.
No. Eye movement. Eye movement is extraocular movement, diplopia.
The H shape.
RBP positive. Or APD.
RAPD. Okay.
the-
Afferent pupillary deficit. We are testing the optic nerve afferent section. That is known as Marcus Gunn phenomenon. Marcus Gunn phenomenon. Alright?
So basically, we just the RPD, we just shine on the pupil.
Swinging touch. 1, 2, 1, 2, 1, 2. When you go and you come back, the affected pupil will dilate. From big hospital, it will dilate.
The pen touch is directly on the eyes or just above it?
When you are doing Marcus Gunn, you can directly on the eye, you can see what.
Okay.
For the gap reflex is 9 and 10. So we cannot know which one of it is.
Good question. 9 is the sensation.
Yes.
10 is the feeling. If you have a pathology of 10, you may not get the gag response, but the patient can feel.
So you'll be
So you must ask them, do you feel or not?
Oh.
Just ask them whether they feel. Gag is not vomiting, it's not the same thing. Vomiting, retching reflex is completely different. There's a relaxation of your upper esophagus sphincter, contraction, violent contraction of your stomach, downward movement.
They also used to like check in case any inflammation, right? Like usually in the clinic.
Inflammation, what sort of
It means like the sore throat.
sore throat? You don't do a gag reflex for patient with sore throat. If you are a general practitioner, you will go bankrupt.
What's the I don't
No,
know.
tongue depressor is used to push down the tongue. It's Byron is used to push down the tongue. You can do that if you want to say, do they feel sore or not, but I don't really recommend it. If you are really assessing a gag reflex, why you need to do it? You need to test both sides because you have a pair of cranial nerves, not one. You shove the tongue depressor in, besides the fact that it's quite this one. You don't know which side you're stimulating, right? You're going to hit in the middle.
So you're gonna hit the side.
You need to see both sides to see which side is accessible. By right.
But in exam, you just
By right. Both sides. Yes.
It means you have to repeat it or one shot.
You can quickly touch what and see what.
But the moment we touch the first time,
That's why you have to be fast and you have to be subtle about it, If you take a tongue depressor and shove it in,
It's one thing. And also one more thing, to test the hearing, we need the liver test. Actually, we are asking the patient to feel for the vibration or to listen to the sound. Yes. Very sharp sound.
for the vapor, it's definitely feeling for the vibration. For the really, actually, it's a little bit of perception of the sound also.
So basically, we ask them, okay, tell me if you stop feeling the vibration or
Okay, AC there are two ways to do it. The one way I showed you is the very rapid way, front back, which is louder. Another way is you put the tuning form on the master process. Okay, tell them to tell you when it stops. Then immediately shift it forward. Okay, so if he says okay, it stops, then you can even compare with your hearing if your hearing is intact. So that way you can even pick up subtle reduction in hearing.
so it's the vibrations. The sound. Sounds like just a temporary.
For the
And then one more, but the vibration is still.
yes. Alright. Known as your this thing, your what do you call it? Either your whole pipe maneuver or your this caloric test and all these things. Yeah. That's usually used in a comatose patient. In a conscious patient, it's not routinely done.
You guys mentioned one lateral palsy convergent squeeze.
No, in lateral rectus palsy, if you have a sixth nerve, what happens is the third nerve is unopposed nerve.
Yes.
So it will pull the eye medially. So it will be convergent. One eye is straight, one eye is squint. If you have a third nerve palsy, the lateral rectus will pull the eye outwards. So it's divergent. just a simple examples lah. There are more complicated examples. Screen can occur due to abnormality in the mechanism of conjugate eye movement. The thing that the effectors that control the eye movement, although the extraocular muscles are completely normal, there are higher centers lah, or something known as the pontine paramedian reticular formation, but that's way out of your what you need to know lah. Not even nice to know. No need to know. Don't worry. There are more important murmurs and other cardiac rhythm which you need to know than this at this stage. Alright? If I sign, if I have not signed.